just as luck would have it, the health coach I was working with, who's this amazing guy, he was very knowledgeable about ketogenic diets. So for some of our trickier patients, he suggested, why don't we start this guy on a keto diet? And of course, my first reaction, given my training, was, what, are you crazy? I don't want to kill the guy. That was how I was trained. But luckily he pushed back and said, well, have you read about it? Have you done research about it? And I said, well, no, I'm just sort of being a parrot and saying what I was taught. So I dug into it, and boy, was I surprised. There was actual scientific studies and research about the metabolic benefits of ketogenic diets going back to the early 2000s, and of course, Drs. Finney and Volek, they've been researching it and publishing about it for decades. And so all of a sudden I was like, why have I not heard about this other side of this diet? And so then just went even deeper, tried it on myself, and then started trying it on a number of patients, just started reading everything I could get my hands on. And all of a sudden I was all in. And again, not that a keto diet is the one diet for everybody, right? We fell into that trap by saying the low-fat diet is the one diet for everybody. So there is no one diet for everybody, but a ketogenic diet or versions of a low-carb diet need to be in every nutritionist and every doctor's toolkit as an option for the right setting. And so that really became my mission, to shout that from the rooftops as best I could. So I started the Low Carb Cardiologist podcast, then was fortunate enough to meet up with the crew at Diet Doctor with Dr. Andreas and his team, and then joined Diet Doctor to run the Diet Doctor podcast, and now kind of help with the content there as the medical director. And so the rest is sort of taken off. Now, the one sort of pushback against low carb and keto diets tends to be lipids, which so puts me in a very interesting position. Which I guess we can get into the details, but it definitely does go against a lot of the training. But I'm not just sitting here saying I believe it's not a problem. I am focused on the literature, on the science, on the clinical experience to try and educate people about a different way to sort of see it. So yeah, that's my journey up to this point.
Well, I think what you're describing is really the true definition of evidence-based medicine. A lot of times when we hear about this is not evidence-based, that lacks evidence, what we're really referring to sometimes is just what exists in the literature. And while I think that that's important, there's almost like a Venn diagram in terms of what evidence-based is. One is like the available literature, which you said there's already kind of a robust amount of information that will denote some of the benefits that the ketogenic diet has on lipids, on metabolism, on brain health, on longevity, all those things. And you're also in the trenches in a way with your clinical results with some of the patients that didn't respond to some of these other interventions that you had tried initially, which was very likely a low-fat approach. Patient wasn't able to adhere to it. And then with some of these tweaks, maybe switching the macros around so that let's say the majority of their calories might have been fat, and then we pulled back on the carbohydrates. That clinical evidence, albeit it's not an RCT, it's not a Mendelian, it's not Mendelian randomization. However, it's still evidence. So I think that, and then as you accrue that, I mean, at least that's been my experience as a clinician. It's like, I've never written a paper, but I do have thousands of case studies that have been able to predictively, at least for me in my practice, be able to, and we're going to talk about labs and stuff today as well. When you're doing it with context, when you have, data like LP little a and total cholesterol and LDLs and particle numbers and all those things, there is a pattern that does emerge. And I think that, and maybe my question to you here in that long ramble is what would you like other cardiologists and maybe just, primary care physicians to know about the ketogenic diet?
Yeah. I mean, I think before talking about the ketogenic diet, I think we have to talk about metabolic health and the importance of metabolic health. And that metabolic health is cardiovascular health. It's not one or the other. They are one and the same. Metabolic health is mental health. Metabolic health is, autoimmunity, right? It's linked to so many different aspects. So the focus, I think, really needs to be on metabolic health. And then once you acknowledge that, then you can see the effect a ketogenic diet has on metabolic health. And it is better than anything we have. I mean, it's better than any nutritional intervention, is better than any drug in terms of lowering insulin and lowering glucose and improving triglycerides and HDL and the size of your LDL particles, the things that are related to metabolic health and blood pressure. Like the one-stop shop for all that. I think it's not that it's the only way to achieve those goals, but I think from a lifestyle intervention, it is the most effective. So the first is recognizing the importance of metabolic health, and the second is recognizing the impact ketogenic diets have on metabolic health. And once you can put those two together, I mean, there's no turning back, because that's when it needs to be an option, at least an option for just about everybody you see who is overweight or has type 2 diabetes or prediabetes or insulin resistant or autoimmune conditions or any concerns with metabolic health. It at least needs to be an option that you can offer in that subset, and then know how to follow people appropriately. And that's a lot about what we do at Diet Doctors, providing as much information as we can so people know how to either start a diet themselves or start a patient or client on it, and then how to follow over time to make sure there can be side effects, there can be changes in labs, and we have guides about all these things to help the clinicians through that process. Because we don't want there to be barriers for them to not start people who could benefit from a ketogenic diet or versions of low carb diets.
Yeah. And one of the observations I have made, and this was relatively early when I was first starting implementing the ketogenic diet with some of my patients, is patients who are co-managed. So my practice, I'm trained as a chiropractor. So we would have patients coming in with, let's say, back pain or headaches or whatever. And then there would be like the physical corrective care that we would do. But so often it wouldn't be just like, let's say, the manipulation or the rehab that would provide them with the long lasting results. There also had to be like a chemical manipulation. So if the patient was always consuming, let's say, processed foods, or, they were consuming a very high sugar or a very high, something that was causing some of these labs to get driven up, these inflammatory markers that you were mentioning, the glucose or the, HCRP or some of these other indicators of systemic inflammation, I would always implement a diet as well, because you can't really talk about exercise and nutrition separately. They're one and the same, in the same way that we know you can't talk about the brain and the body separately. It's like, one and the same. And by far, when I was starting the ketogenic diet with these patients as a means, as a transient therapeutic intervention to try to bring down inflammation, if they had a primary healthcare provider, let's say a medical doctor, more often than not, I'll say not always, but more often than not, the medical doctor would be very much against increasing fat consumption.
Yeah.
It would be very much kind of in the line of, of your school of thought, of your teachings, right? From your teachers in school, it would be like very much a low fat approach. And the communication was always, but your total cholesterol, like, we're really concerned with your total cholesterol. And
Yeah.
I have landed, and I would love your thoughts on this, because I'm very open to being wrong. But it seems like total cholesterol, and maybe this is an extreme statement, but it seems almost useless if it's not contextual. If I don't understand other markers, like if I don't have an LDL particle number, if I don't have, let's say an HDL and a triglyceride ratio or an LDL, like if I don't have those numbers, the total cholesterol, as an independent predictive marker is almost useless. And maybe that's an extreme.
Yeah, I agree. No, I don't think that's so extreme. I think total cholesterol is pretty worthless, especially given all the different variables we can measure now, right? So of course, LDL, HDL, triglycerides are all part of the standard lipid profile, and they are far more useful than total cholesterol. So I agree. Throw out total cholesterol, look at LDL, HDL, triglycerides. But even better, can you get an ApoB? Can you get an LDL particle? Can you get a size of the LDL particles? Those are even better than just the standard LDL, HDL, triglycerides. Of course, I want all of those together, but you are absolutely right. Total cholesterol should be thrown out the window. But I do want to go back to one thing you said when you were talking about evidence basing. Because, this is a term that's thrown around so much. And all you have to say is, oh, this is evidence-based. Then we're supposed to say, oh, okay, that's all we need to know. Absolutely not. We need to know what level of evidence there is. What are we talking about evidence? Because you can point to, it's evidence-based that high-fat diets are related to heart disease. That is a true statement. But then what level of evidence? Well, the worst, lowest, most unreliable level of evidence is what points to that association. So once you know more about the evidence basing, same for, I guess you could say same for total cholesterol. You could say total cholesterol is associated with cardiovascular risk. That is an evidence-based statement. But what type? Observational of big populations where, everybody's probably got metabolic dysfunction and eating a high fat, high carb, high calorie diet. Okay, now we can put that into context so we know more about the evidence rather than just saying it's evidence-based. So I think that's a trap that a lot of people fall into. And, it's tricky because as individuals who have no science background and no medical background, like how are you supposed to be able to interpret studies and know the strength of the studies? Correct. And that's why I think everybody who's talking about evidence-based needs to be clear about the strength and the quality of that evidence.